91, pero muchos de los esfuerzos que hemos hecho y con los cuales nos sentimos muy orgullosos y vamos a seguir haciendo muchísimo énfasis durante todo el foro. Ustedes encontrarán temas como si es posible, como volver a lo básico, porque en muchas reuniones que hemos hecho con personas que están aquí acompañándonos, hemos encontrado que nos falta mucho camino, pero además entender de dónde nace todo esto. Gracias, Tere. Y como Tere lo anunció, seguimos con la doctora Sheila Leatherman, con la conferencia El enfoque sistémico para el mejoramiento continuo en países con ingreso medio. La doctora es profesora de investigación de salud pública global en la Escuela Gillings de la Universidad de Carolina del Norte. Dirige investigaciones y análisis políticos internacionales, centrándose en mejorar los resultados de salud, la reforma de salud, las metodologías para mejorar la calidad y evaluación del desempeño de los sistemas de salud. Hace más de 10 años, trabaja en el Reino Unido como evaluadora independiente, analizando el impacto de la calidad de la atención en el Servicio Nacional de Salud de Inglaterra, NHS. Es autora de varios libros sobre la calidad de la atención en salud infantil y para adolescentes. Recientemente publicó el primer informe nacional de calidad de Canadá por la Fundación de Investigación de Servicios de Salud de Canadá. Su trabajo se ha centrado en el diseño de estrategias para integrar las microfinanzas y las intervenciones de salud en comunidades de bajos ingresos de Asia, África y América Latina. Fue elegida por la Academia Nacional de Ciencias de Estados Unidos en 2002 como miembro del Instituto de Medicina y se hizo miembro honorario del Colegio Real de Médicos. En 2007 fue galardonada comandante honoraria del Imperio Británico. Les recuerdo que esta conferencia es en inglés, por lo tanto, quien necesita traducción simultánea, los equipos estos se encuentran afuera. Doctora Sheila, realmente es un placer para nosotros que esté aquí en nuestro país visitándonos. Cartagena y Colombia le da la bienvenida.
Buenos días y muchas gracias. I'm really pleased to be here in Colombia. I do a lot of traveling and working around the world, but for years have been trying to get here. And so I'm very pleased to be here. And also very pleased to be following the talk that Teresa gave, because she's given you the basis of what the state of quality is in Colombia. And I think you'll be able to be not only inspired by her remarks, but also use that to kind of realistically, thank you, look at some of the frameworks that I'm going to present today. So the work that I do around the world is usually at the national level of countries. Working with ministries of health or large healthcare systems, as well as a lot of work in data management, measurement, and evaluation. Today I'm going to be talking about a systemic approach to improving healthcare quality. And I want to start with just a few facts. This is recent data that actually came from World Bank and Institute of Medicine from several countries, I'm sure not Colombia, but the data showed that only 30 to 50% of patients receive the right diagnosis, and about half of patients seeking medical care receive actually safe care. So let me state that a different way. Only 1/3 to 1/2 of patients are being diagnosed right the first time, and almost half are actually getting harmful care. But that's not just in low and middle income countries. If I were to show you data from the United States, there's been some very well-publicized data that shows in chronic disease, Americans who, as you know, we live in a very rich country and that spends a lot on health care, but even in that country, people with chronic disease only get about half the care that they need. And this from Europe just shows another example that quality suffers worldwide. It's hard to read the countries. There's about 9 countries there. And if you simply look at the top trend line, that's France, and the bottom trend line is Netherlands. This is showing the variation in prescribing antibiotics in primary care. And it's about 3.5-fold difference. And that's not likely to be explained by medical or clinical need. So in every country around the world, we face quality and safety issues. So what I'm going to be talking about is how to build systemic quality strategy in countries. In most countries around the world now, there is really a focus on quality. This is from the most challenged countries, and I'll show you data from some of them, to the richer countries. And particularly now with the new Sustainable Development Goals and the push towards universal health coverage, we need to focus on quality even more. Quality sometimes among some countries is considered a luxury. For richer countries, I would make the argument that it's quite the opposite, that in those countries that have the least resources, those are the countries that need the highest quality of care because they can least afford mistakes. So I'm going to talk about a national quality approach, and I think this will fit well with what Teresa was just talking about. I'm also going to be talking about creating systemic capacity at 4 levels of the healthcare system. And I just want to get, if you'll raise your hands, I just want to get a sense of who is in the audience. So how many of you are working in hospitals or clinics directly in patient care? Like high up. Okay, it's a long way to see. Okay, how many are working in policy or management positions? Okay, that looks like the majority. How many are working at the national level and regional levels or local levels? Okay, very good, thank you. So I think this will pertain across the various levels. I then want to talk about best bet interventions, and we'll explain that term. And finally, to end with some basic building blocks that apply across the board, whatever country you're in. So we're going to start just with a few concepts, defining quality. Quality can be defined in many different ways. There isn't a right or a wrong definition of quality. This is the one that countries or hospitals often start with. This was from the Institute of Medicine in 1990, and simply says it's the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. In a number of the countries I work with, I work in a lot of lower income countries, we also add consistent with current professional knowledge and within available resources, because the reality is a constraint of resources in many countries. Next, there's usually a definition of quality and then also dimensions of quality. And these are the 6 that are considered the universal language, but countries often decide to focus on just several, that the list is just too much, and they pick out several of those and focus, and that's fine. And certainly at the level of hospitals, clinics, again, they might choose to focus on safe care that patient and family-centered. But knowing what the universe of these dimensions are can be helpful. And the last concept I want to introduce is Duran's trilogy, and I think this actually aligns with the figure that Teresa was using of the 3. So Duran came out of industrial quality. In fact, healthcare has adopted a lot of industrial quality concepts. And what he said is that if you want to be successful at improving quality in a reliable and systemic manner, that you need to have all three of these functions. Quality planning, which might be policies, or it might be building infrastructure such as information systems. You need to have quality control, like risk management and infection control in hospitals. This would refer to the processes that Teresa was talking about. And finally, quality improvement. That is rigorous improvement using methods that have some evidence behind them and measuring to make sure there is improvement. So with those three concepts, I'm going to talk about creating systemic capacity at all levels of the healthcare system. I use this model and have used it across countries as different as working with Afghanistan to working with England and the US, and it seems to apply across the countries. It simply says that if we're going to systemically build capacity for quality in a country, there are certain functions that need to be done in every country. And at the national level, that is policy formulation as well as infrastructure. Infrastructure might be building a workforce or, as I said, information systems. At every country has some regional level, province, state, district. And at that level, there's always some kind of service delivery as well as performance management. And I would add there that often the task and the challenge of regional offices is to make sense out of what is being handed down by the national level and to make it doable and sensible. At the level of institutions, these might be hospitals, clinics, dispensaries. Good governance is essential. That's leadership and good governance, as well as competent operations. And then finally, at the level at which healthcare services are taking place, again, there has to be competent health services provision. And all of us as humans, whether we're healthcare workers or patients or families or managers, need to be acting responsibly and in the interest of the patient. So far we have some broad concepts, and we also have the 4 levels of the healthcare system. Probably what I have learned most, and have worked in quality several decades now and probably across maybe 20 or 25 countries, is that it is selecting the right interventions and implementing them in the right way that makes the difference. And I am a researcher. I spend a lot of my time actually evaluating interventions to try to figure out what works, and would have to say 2 things. The bad news is we don't know as much as we need to know, but the good news is we're getting a lot smarter. So best bet interventions is something I talk about in a number of countries, and that is to try to really understand what are all the methods and interventions available to you, and then to pick wisely. And there's never one thing that works by itself. It always has to be done in a combination. So this just gives you an idea of what's possible. Again, the notion here is quality is not a luxury. And countries that are challenged by underfunding of healthcare expenditures need to be as attentive to quality as any other country. The stakes are high, but I think what is truly inspiring is, so can the consequences be really important? This is just looking at 2 hospitals from South Africa and the attempt to reduce death from severe malnutrition. And if you look at the before guidelines data there, about half of the patients who came into this Mary Teresa hospital died from severe malnutrition. After guidelines were implemented, they cut the death rate by half. And similar progress in the Sepetu hospital, even more dramatic with new doctors. What I want to say, though, is it wasn't just guidelines that were written and implemented. That actually required standards to be developed, good training, supportive supervision, clinical mentoring, and a number of other steps. But you can see that the results are dramatic. This can be done at scale. This is from a country in Africa, Ghana, and this is a project that has been funded by Gates Foundation for 5 years and is a collaboration between the Ministry of Health, Catholic Health Services that basically runs the healthcare systems in Ghana, as well as the Institute of Healthcare Improvement. And again, they did a systemic intervention using standards, using educational collaboratives, training clinical networks, feeding back data to people on their performance, and over about a 2.5-year period, were able to reduce infant mortality by 20%, and this was in 132 hospitals across the country. So back to evidence-based interventions. It's critical to get them right. And I find that one of the challenges that we all face, whether we're working in hospitals or working in the Ministry of Health, is we're not even sure what is the universe of interventions to select from. So I suggest that a classification system is important for people to understand fully what's available. There are many patient-focused interventions. There are many regulation interventions. There are all kinds of incentives, financial as well as non-financial, many different kinds of interventions using data and information. Organizational interventions such as team building, clinical networks, again, many under that category. And finally, care delivery models where you're working essentially in vertical or technical programs and have change packages for maternal and child health or HIV care. So these are just 6 buckets. There may be others. But the point is that there are many interventions that you have to select through using wisdom and experience and evidence. What I find, though, is how do we select interventions to improve quality? And again, this is true whether working in the UK or working in other countries. Interventions basically are selected because it's something that we've heard about. It's ideological alignment. People who believe in healthcare markets and competition choose that. If they don't have that ideology, they don't. Very often it's what someone knows how to do, which is a practical way to choose methods, or something that someone's read about. But the point is, and I think if there's anything that I could wave a magic wand about, it would be that we would all get a lot smarter on understanding what are the whole set of interventions to select from and how to make the best choices. So I want to just go back to this to show you that even if these 6 buckets are right, and I don't think they are complete and exhaustive, but there's about 30 to 50 interventions just in this classification. So if you're looking at this and you're trying to figure out on a ward how to improve diabetes care or how to expedite admissions to an emergency department or how to improve HIV care in a country, you might be looking at least 30 to 50 interventions. And they're very, very different. If we're talking about using data and IT-based information, it's very different if you're choosing to put in an electronic medical record, or if you're using clinical decision support, which is very underutilized around the world and doesn't have to be fancy. It can be in a paper record. Whether you're using public reporting at the national level to compare all hospitals across the country, Or number 5, if you're using feedback to providers, giving them their own data of standards and adherence. The same is if you were looking at patient-focused interventions. Again, these are very, very different. It might be putting patients on hospital boards, but it might be using self-care methods to teach people how to care for themselves, or using citizen action groups like Mexico has used. The point being is there are many different interventions to choose from, and it requires careful study and investment because it is expensive in direct costs and indirect costs when you choose interventions to go forward. So what does this look like as we start putting together? If you're building systemic capacity in a nation or in a region, so this doesn't have to be the whole country of Colombia, it might be one of your states or provinces. It means that you're selecting interventions at all of these 4 levels that can support each other, catalyze each other, and complement each other. So at the national level, it would be national goal setting, regulation, accreditation, public reporting, potentially. And at the level of individuals, it might be performance contracts for healthcare workers, physicians or nurses, certainly professional and peer appraisal, the use of supportive supervision and training. The idea being that you carefully construct what are these various interventions at all 4 levels. I would also say another way of thinking about this is engaging key actors or stakeholders, and it's one of the reasons why I asked who's in the room. It sounds like you have a good mix of people in the room, and I know representing more countries than Colombia. What you want to do is get all of the key actors doing what they do best, to use their influence and their power, their resources in the best way and in conjunction with others. So it usually is the role of government to articulate national priorities, to provide essential infrastructure, funding, policy, and IT, to assure minimum standards, to use some kind of public reporting. And what's often underutilized is what's sometimes called the power of the purse or purchaser clout. The people with the purse strings are able to influence quality and motivate it. In terms of healthcare providers, whether this is individual physicians, nurses, pharmacists, or at the level of hospitals and clinics, again, they have their own set of activities. Standards of care often are said to be at a national level, but they should be coming out of the professions, and it should be nurses, doctors, the multidisciplinary teams that are creating the standards, using them to rigorously monitor and do peer review, to self-regulate using licensing, as well as to develop decision support methodologies. And at the public and patient level, they have their own role, community voice, use of patient and family choice and selection if they are given that ability. So you want to get all of the key actors using exactly what their powers are to influence and to motivate. When you put this all together, countries can do this in a diagnostic way. And for England, I've worked there for 20 years. They're on about their 4th national quality strategy that's refreshing at about every 5 years. And they are able to map in what they are currently using, figure out what's not working, identify that gap, and then put in additional interventions. And they're able to show this kind of map across the country, so hospitals understand their part, professional societies, the ministry, et cetera. This is a different example, and I won't say too much about it because Dr. Ruelas is going to be speaking, but this is from Mexico, and I think they also are on at least their 3rd refresh of a national quality strategy. And what I wanted to show you here is that, in fact, they added in another level. So they've put the community in as well. And you can see that they also are able to map in what is present at various levels of the healthcare system. And I'm not sure what Enrique is going to be showing, but over their different national quality strategies, they're putting in new interventions and taking out ones that didn't really work. So again, I want to go back to what's at stake here, and also the idea that quality isn't just for the richer countries. It's not a luxury. This may be hard to read from all parts of the room, but this is from the country of Niger in Africa. And Niger is, if you know the Human Development Index that ranks countries according to socioeconomic, education, political, security, et cetera, Niger is one of the most challenged countries in the world in terms of adversity. They wanted to reduce maternal mortality and addressed it by putting in a protocol, set of standards, training, support, data monitoring around active management of third stage labor. What you see in the dark blue is the rate of adherence to the standards and to the protocol. What you see in the pink is the reduction of women dying from childbirth. So again, you can see that this is very dramatic, could be done across a country and a very poor country. So the question might be for you in the audience, and I know there's a number of countries, I just listed Colombia, and I think actually with Teresa's comments, we would actually be able to write some of the things in now of what you do have operating in terms of a systemic approach, and also what the gaps are. I want to end with going through these 10 to-dos. These seem to apply across every country, every hospital, and to be fairly non-controversial. And I'd like to recognize my colleague, Enrique Ruelas. We came up with this for a meeting a couple years ago in Mexico. Leadership is obviously critical in shaping the entire environment, and that's leadership at every level. Setting standards with targets, again, is critical, with numerical targets of some sort. Professional and institutional licensure, which Teresa talked about, is fundamental, and it sounds like you've made a lot of progress here. There are countries, and I got permission from my colleague Trina from Ireland, there are countries like Ireland that have many of the other pieces, but they don't even have licensing of hospitals yet. So it's again why you really want to map in the different interventions and understand how these work together. Workforce development, of course, incentives. Hopefully we'll talk about incentives throughout this program. There are those who believe that pay for performance is the answer. I'm one who thinks it's a partial answer, but not the answer, and that there's also other kinds of incentives to use around enhancing reputation, awards, et cetera. Measurement, benchmarking, and feedback is critical for those who have an interest. I know there's several workshops or sessions, including one I'll be leading tomorrow. I think what is really changing about the field of quality is that quality, for the most part, even in those countries or healthcare systems that were doing it well, was piecemeal. It was in a healthcare system. It was in one department at a hospital. But now there is increasing interest as well as skill and experience to do very large-scale population-based initiatives across countries or across regions. Patient engagement, we all know, is critical. Transparency with public performance reporting. I know I've had discussions in the past with people from Colombia, and I think transparency is an issue under discussion, but maybe not enacted widely. And finally, as Teresa was talking about, some form of external evaluation or accreditation. So this is a different way of thinking what the basic building blocks are to build systemic capacity. So questions for your consideration across the next several days would be, what of this systemic approach fits within your setting and your country? What are the most important drivers of healthcare quality in your setting? And what steps are needed to move forward? And I want to end with a favorite quote because I think it says it exactly. Quality is never an accident. It is always the result of high intention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice of many alternatives. Thank you.